डॉक्टर सुदीप सर, सराफ सर कहाँ गए?
हाँ है
He's here, sir.
तो स्टार्ट किया जाए क्या? आवाज जा रही है सुदीप?
आवाज आ रही है।
We have to wait for Dr. Shyam's not. Dr. Shyam will tell us when we are live. Exactly.
Okay. 3, 2, 1. We are live now. We can go ahead.
Madhusudan.
Go ahead, sir.
Dr. Madhusudan, sir.
अनम्यूट होइए मधुसूदन जी, अनम्यूट होइए।
So good evening everyone for this fabulous evening, weekend evening, where we have all assembled to hear from Dr. Ashok Rajgopal, and we from Bihar Orthopaedic Association President and Secretary are really honored to have sir as our speaker and sharing his wisdom and knowledge, vast experience to the listeners of this channel on various platforms apart from Zoom, YouTube, and Facebook Live. And it would be really wonderful for all the young and accomplished surgeon to hear from one of the India's pioneer surgeon, if I may say it that way. So Dr. Madhusudan sir, if you can start the proceeding, please.
Thank you, Dr. Sudeep. Thank you, Dr. Sudeep. Good evening, everyone. Respected President BOA, Dr. Sarraf sir, our respected speaker, Dr. Ashok Rajgopal sir, our moderators, panelists, BOA members, all the audience, and Ortho TV. It's my privilege to welcome you all to today's webinar. The topic is 10 commandants of the total knee arthroplasty. Today we are very lucky that our speaker is Dr. Ashok Rajgopal. He is a very renowned orthopedic surgeon. He is a very renowned joint replacement surgeon of our country. He is group chairman of the Institute of Musculo-Skeletal Disorder and Orthopaedics in Medanta, medicitygurguram. This program will be very, very beneficial for all the BOA members and all the audience. So I wish you all for the grand success of this program. Thanks. I request our respected President of the BOA, Professor Dr. Sarraf sir, to say a few words.
Good evening, everyone. On behalf of Bihar Orthopaedic Association, it is an honor to welcome Dr. Ashok Rajgopal ji. He is internationally renowned orthopedic surgeon, credited with close to 20,000 arthroscopic and over 35,000 total knee arthroplasty surgery. He was honored by Government of India in 2014 with Padma Shri, and also has been awarded with BC Rai Award by MCI. Clearly, he's a pioneer in the world of orthopedics. I also welcome all the faculties, moderator, and Ortho TV Coordinator, Dr. Ashok Shyam and Shamsul Hoda. I am sure this webinar is going to be very informative and interactive. Now I formally announce the start of this session. Thank you. I hand over to moderator Sudeep ji.
Okay, and welcome all the panelists and my co-moderator, Dr. Vipin, as well.
Thank you.
So without much ado, I think, sir, if you can share your screen, we'll and we all will keep mute, and sir will be sharing his screen and starting his presentation. Yes, sir, it's visible. Your slides are coming.
Good evening, friends. I'd like to start by thanking Dr. Sarraf, Dr. Madhusudan, all the moderators, panel, and everyone who is logged in and tuned in. Let me start by saying that it's an honor and a pleasure to be sharing the screen with all of you. I was asked to talk about the 10 commandments of total knee arthroplasty, and want to actually walk you through certainly my philosophy of knee replacements. I would start by saying that this is a session where I would encourage you to ask as many questions as you want, both from the panel, from the moderators, and it'll be a real pleasure to interact and try and answer the various questions. So the format is I have a few slides, and at the end of the slide there is a video demonstration of about 9 minutes that captures all the essential points of the presentation and the talk. And at the end of it, we're very, very happy and would encourage all of you to, discuss, and we will try and address all of those questions. So the real issue with total knee replacement is we started off by saying, what are the patients, who are the patients who need this surgery? So for a long time, as Dr. Sarraf started to ask me, why have things changed, or have things changed? Are we in sync with what's happening in the other specialties? So let's walk our way through some of these questions, and we can debate them at length later. So there are basically 5 issues that you need to understand when you contemplate doing a knee replacement. The first is the indication. The second is the patient selection. The third is the implant selection. Then, of course, you have the surgical technique. And then possibly what I believe is the most important part of knee replacement, which is your rehabilitation process and the issues. So let's start walking our way through some of these. Indication issues may actually sound very obvious, but you'll be surprised at how many times a patient is operated for a knee replacement because he complains of pain in the knee because of referred pain, which may be from the spine or the hip. There are issues in the abdomen, the pelvis. So the first point is, when you see a patient, make sure that his pathology or pain in the knee comes from a disability or pathology in the knee. So what I'm really sort of mentioning here is a thorough clinical examination is mandatory before recommending a total knee replacement. Very often, we've seen this way too often. A patient undergoes a total knee replacement, is not satisfied, continues to complain of pain, and eventually you find that this patient has osteoarthritis of the hip with the referred pain into the knee, and not surprisingly, he is a dissatisfied patient. Now, the second point is patient selection. And the most important thing is to understand before you start that you need to identify those patients who whatever you do are not going to do well. These are patients who have psychological issues, who are stubborn, who will not listen to reasoning. There are a lot of patients who do not have a lot of family support. The typical example are families whose children are overseas. They come here for 2 weeks, get the surgery done, and they leave, and then the patient is left unsupported. They may not be able to understand instructions, and they don't know how to reach out to the treating surgeon. And the most important individual in this category are patients who have unrealistic expectations. And we'll talk through this. For instance, a patient who's been bedridden for about 5 years, has never walked except on a walker or wheelchair, expecting to be able to sit cross-legged on the ground and walking 2 kilometers 2 months after surgeries. These are the patients who are not going to do well. You should be able to identify those. The third issue really is the implant selection and your pre-operative planning. I think this is the key to success. I have over the years stuck with 1, maximum 2 companies. And I'm not trying to recommend one or the other, but what I would very strongly advise is get comfortable with 1 implant system, maybe 2. And when you are operating on these patients, make sure that you have all the size options, all the different inventory for the types of constraints, the various polyethylene types, and most importantly, in difficult surgeries, make sure that you have an option that in case your plan A does not work, you have a fallback plan B, and for the plan B, you have the appropriate number of implants or sizes or different types of knee systems available to you. So the pre-operative planning is very necessary. I think it's important that you see these patients clinically, you get the radiology, you get weight-bearing x-rays, you x-ray the pelvis, you x-ray the lumbosacral spine, check the peripheral vascular issues. Long legs x-rays are particularly important because if there's an extra-articular deformity, you might miss them if you just get the knee x-rays, which is why we always emphasize that long leg x-rays, what we call the alignment x-rays, are very, very important before embarking on a total knee replacement. These are the short x-rays, which will do in most cases, but even as a scanogram, just look at what the overall limb alignment is, because very often you might have a pathology in the hip or in the shaft of the femur or the tibia, and if you don't factor that in, you'll probably end up with a malaligned limb. These are templates that are available with most implant systems. I put this really for the sake of completeness. Honestly speaking, today, we almost never used templating, but for those of you who are starting off, I would very, very strongly support the idea of getting your company man to bring in the templates, template these x-rays, make sure you factor in that these are 15% enlarged, and accordingly, you can choose your sizes. So if you have a challenge of having maybe 2 or 3 sizes, you'll be pretty close, one size up, one size down. You don't get stuck out for want of the right size. Now, there are really 10 key points, and these are what I call the 10 commandments. You can vary this any which way that you want, but these are the essential 10 things that you have to do before you get a good knee under your belt. The first thing is a proper exposure. I mean, we've all been through, those of you who have been in the business long enough, in 2002, 3, 4, 5, we had this magic word called the MIS, knee replacement surgery, which was the biggest disaster. Both on the hip side and the knee side, people were competing with each other. 4 centimeter incision, 5 centimeter incision, 6 centimeter incision for hips and knees. And that was an absolute disaster. There is no place for MIS in knee replacement or hip replacement. You do not need to make a 14-inch incision, 4 to 5 inch, but make an incision long enough for you to be able to see. You have to have a standard in your mind. On the femoral side, our typical go-to is for a varus knee, we use 5 degrees of valgus. For a valgus knee, we go to 3 degrees of valgus. We believe in the philosophy of the mechanical alignment. There are now 5 other different ways to align the implant. We have stuck to the tried and tested with that I started almost 35 years ago. And we cut the tibia at right angle to the shaft, and we cut it in about 5 to 7 degrees of posterior slope. I'm primarily a CR cruciate retaining surgeon, so that works well for me. If you're a PS surgeon, you do it at about 3 or 4 degrees. You ensure correct femoral and tibial rotation, and I cannot overemphasize that this is the key to getting a good knee. You need to balance your flexion and extension gap. Make sure that you're not oversizing the knee, because that is stuffing the joint, and you'll have stiffness, you'll have pain, you'll have movements which will be compromised, and overall a very dissatisfied patient. We started off in 1987, 88. For almost 10 years, I did cementless knees. They did very well. For various reasons, cementless was not available, and since 87, we have been, since 97, we have been cementing all our knees. And there is a technique to it, and we'll just very briefly talk about this as we go along. What sort of cement do you use? Do you use antibiotic cement? We typically use antibiotic cement only in patients who are at risk, patients who are diabetics, who are rheumatoid, immune compromised, renal or liver transplant, post-malignancies, patients who have had immunosuppressants. We then come to the ninth issue, which is start your physiotherapy, physical therapy early. Talk to your patients before surgery that they will need to rehab, and start their rehabilitation early. And last but not least, if you do happen to be unfortunate to have a complication, recognize it early, treat it aggressively. So the long-term success depends on these 4 issues. You have to have your limb aligned, your joint aligned. You need to make the right bone cuts. You need to have the right soft tissue balance, and you need to have correct rotation. And these are all 25% of the 100% that you need to get a good alignment. I worked with John Insall, and at the time in 99, 2000, when I was with him, he always used to talk about knee replacement surgery being a soft tissue surgery. Today, we know that is only partially true. There's a lot more to knee replacement than just balancing soft tissues. And some of these are outlined in these 4 pointers. Now, typically, if you do a knee that is not done correctly, you see these x-rays. These are all mal-rotated x-rays. And this is very easily done, particularly in obese patients who are stiff, where your exposures are not good enough. And you will find that the x-rays on the left are all preoperative, they're malaligned. And the way you diagnose that is if you see the x-ray on the left, the femur looks a perfect AP, while the tibia looks, the lateral side flange is much longer. So that tells you that your tibia is internally rotated. The same thing on the x-rays to your right. The preoperative x-ray, you see that the medial flange of the tibia is longer than the lateral one. And both of these patients needed revision surgery. So what are we trying to do? We're trying to restore the mechanical axis. What is the mechanical axis? And way back, 1984, John Insall talked about the mechanical axis being correct when the center of the hip, knee, and ankle are in the same straight line. There have been several variations now, and there are various other alignments like the constitutional, the anatomical, the kinematic alignment, the modified kinematic. So there are different schools of thought, but by and large, this has stood the test of time. And today, a lot of the arthroplasty conferences, there are lots of debates on whether the constitutional alignment is better, or mechanical or kinematic alignment. The one thing we know is that you do not want to have your tibia or your femur cut in varus, because in varus, there's 67% chances of failure. Interestingly enough, in a neutral alignment, there's 20% chance of failure. So the most valid way to go about is to have a 6% valgus, which is really what we're trying to do when we are cutting your femur in about 5 degrees of valgus in the distal femur. So these are the fundamental principles. And again, these are John Insall's slides that you very kindly, and these are slides that have become like the Bhagavad Gita of knee replacement presentations. You have a quadrilateral gap. You correct that because by releasing soft tissues medially or laterally, depending on what you want, and you align this so you get from a quadrilateral to a rectangular gap. It's also important to understand the fundamentals of the knee replacement, that the distal femur only influences the extension space, while the posterior femur only influences the flexion space. So once you've understood this part, you understand what your cuts are doing as far as the femur is concerned. We then move to the tibia, and the interesting part is that the proximal tibia influences both your flexion and extension space, which makes the tibial resection absolutely the critical cut and the critical alignment issue. Now, all of you have gone through this debate, and you have, I'm sure, in your own minds been worried about, should you retain the cruciate, should you sacrifice it, should you cement, uncement, fixed bearing, mobile bearing, do rheumatoids do well, do osteos do well, does age influence the outcomes? Let me just sum up this whole slide and answer it in one line. None of these factors make any difference. Your cruciate retaining does as well as cruciate substituting. The young patient does as well as the old elderly patient. Rheumatoids do as well as osteos. Fixed mobiles done well will do almost as well. And if you look at the Australian or the Norwegian or the Finnish or the Swedish registry, there's a 1 point difference between all of these options. What really matters is how you do your surgery, how well you balance your soft tissues, and how well you fix your components. Now, what is the ideal alignment? Again, it is a debatable subject. So I'm going to talk in context with what I do, which is the mechanical alignment, and we use anatomical landmarks. Now, these are easy to find in a primary knee. Most often, they're also easy to find in a revision knee, but we're not going to talk about revisions today. We're just going to talk about primaries. So the anatomical landmarks, we'll just talk about it in a minute. More recent developments, you've had a lot of talk about navigation options. Navigation is out of the window. Very few people actually use navigation. You'll be surprised in the year 2000, of the 100% that were using, 3% have retained navigation options today. We went through the patient-specific instrumentation. This came and it went. And there was really no clear advantage of knee replacement done by under navigational control or conventional control. I'm aware that some of you are familiar with the new buzzword in knee replacements, which is robotics. I believe some of you may have had exposure to this. We have been using it now for almost about 4.5, 5 years. Are the results better? We think it might be at least as good. We do not know if it will be better. But the one thing that is the downside to this is that the costs are a huge issue. They're very expensive. They cost in the region of about 6 to 8 crores. And obviously, realizing that amount of money is going to be a challenge. So in terms of the surgical technique, you have done your exposure. Whatever way you have the mid-vastus, you have the anteromedial approach, you have the subvastus approach. These are the clear approaches. In difficult knees, you can do the rectus snip. Again, these are more revision concepts we're not going to talk about. You then do your bony cuts, and then you do the final adjustment with the final ligament releases. Now, rotation, when you talk about the femur, these are the 4 issues that you need to consider. The AP axis, this is the white side line. You have the transepicondylar axis, which is easy to find, the posterior femoral condyles, and the transtibial axis. So the transtibial axis is used by people who do the tibial resection first. And these are usually going to be your PS surgeons. A lot of them will address the tibia first, they subluxate it anteriorly, do the tibial cut, and then orient the femoral rotation relative to the tibia. I don't do that. There's nothing wrong with doing it that way, except that you have to be absolutely certain that your tibial cut is absolutely at right angles to where you want it to be. But these are all the 4 landmarks. Typically, it helps if you use more than 1 landmark. So we use the transepicondylar axis and the AP or the white side axis. On the tibial side, you can use the medial third of the tibial tubercle, or you can use the extramedullary guide for the first web space. We've modified this, and I would like to say that we now use the tibialis anterior tendon. That is your most accurate index. And if you use that as your landmark inferiorly, you will cut almost always at absolute right angles to the long axis or the mechanical axis of the tibia. And that's really what we use. The second step is to start to remove the osteophytes in a varus knee on the medial side, on the lateral, and a valgus knee on the lateral side. By doing this, you release the tension. In a flexion deformity, you recreate your recess. You create your medial recess, your lateral recess, and your posterior recess. And then you address the PCL. Those of you who are PS surgeons will sacrifice the PCL. Those of us who are CR will decompress and balance the PCL. So on a varus knee, and remember, whatever releases you do will always be sequential. Do a release, check the limb alignment, do a little more. That way you titrate your releases, you do not over-release. And this is what we do. This is the order we follow. The capsular ligament, which is the meniscofemoral and meniscotibial ligament. We rarely go as far as the semimembranosus, except in very severe 30 degrees varus knees. We almost never release the superficial MCL, except in patients with very severe flexion contractures. I retain the PCL in 95% of my knees, and the pes and serenus you will only do when the knee is subluxated by over 35 to 40 degrees. But this is the sequence in order of what you may want to release. On the valgus side, these are the more difficult knees. They're usually rheumatoids. Rheumatoids present valgus, so you start with the lateral retinaculum, the iliotibial band, the fibular collateral ligament. Sometimes you may have to release that. It's extra article. It causes no instability. You then release the posterior posterolateral capsule. I keep the PCL, but if you have to release it, I would subperiosteally release the lateral gastrocnemius. And popliteus is the last structure that you should release, remembering that if you release the popliteus, you might end up with a posterolateral instability. And if you do, then you're going to need a constrained option like the TC3 or the LCCK. So be very careful. In severe deformities, like I said earlier, make sure that you have fallback or plan B options. In severe flexion contractures, release the posterior capsule, remove your posterior osteophytes. Again, recreate the recess. Recess is basically the potential synovial space that normal knees have that gets obliterated in severely deformed knees. You can resect the distal femur, but that raises your joint line, can cause flexion instability. And we have even very severe knees with flexion deformities released the PCL, but retained it, not actually sacrificed it. So this is really what we are trying to do, releasing the osteophytes and recreating the recess. These are the posterior osteophytes. You must remove these because this decompresses your posterior capsule, the flexion space, and you're then able to extend the knee a lot easier. So at the end of your surgery, what is acceptable? You should have 1 to 2 millimeter opening of the medial side in about 5 degrees of flexion, looser lateral side. And if you are a PCL surgeon like me, you may want to make sure that your femur articulates with the middle third of the tibia, as you can see over here. On the lateral side, that's the way you need to make sure that it is aligned. You need to make sure that the tibia is under the femur. And if you, as you flex, the tray starts to lift off, that means your PCL is tight, and you might want to either release the PCL or sacrifice the PCL and go to a PS type of an option. Oversizing the femur will overstuff the joint, or resecting the patella will also overstuff. If you're between sizes on the femoral side, go for the smaller size and make sure that your patella is the same thickness as it was before you resurfaced it. And finally, today, most implants that are available with all the companies that are marketing knee implants, their implants are very patella friendly. So even those of us who do not routinely resurface the patella, we have excellent patellar alignment and tracking. We come to the most critical part. I think this is the make or break. Make sure that you have your anesthetic to very, very good postoperative pain management. Because if you do not do this, the patient is going to be apprehensive. So we use a lot of intra-articular infiltration. We use patient-controlled pumps. We use adductor canal blocks. We use cord box, which means the sciatic obturator quadriceps, the obturator nerve, sciatic nerve, and obturator nerve. And we use the posterior capsular infiltration. Always remember, if a patient is in pain, he's not going to walk. And today our aim, which we achieve, and I think about 90% of our patients, our knee TKR patients will get operated in the morning. By 3 o'clock, they will be standing up and walking. And our unicompartment patients stand up and walk within 4 hours of the surgery. And I think it's very important from a morale point of view that patients are mobilized early. So finally, a successful outcome of a knee replacement is a marriage between a cooperative patient, well-done surgery, and an excellent pain protocol rehabilitation system. And finally, I cannot overemphasize this, the the patient's expectations must be realistic. I mean, patients who are promised 150 degrees of knee flexion will always be a problem child for you, because very, very, very few knees will go to that length. And a realistic expectation is about 120 degrees of flexion. Globally, that has been the recognized figure, plus minus 5 degrees. Either way, you get the odd patient who can do much better, but predict about 115 to 120 and you'll be in the right sort of a ballpark. If you do have complications, we all do, make sure you do not sit on it. Don't think it's going to settle down. They don't. Most important, if your wound is not healing, remember there is no such thing as superficial infection. A knee that is discharging, knee that is bleeding, wait for 48 hours, does not settle. Take the patient back into the operating room, open it up, clean it up, see if you've got a bleeder, see if there is something gone wrong. Is there a fracture? We all treat other people's complications better than we treat our own complications. Make sure you don't do that. And treat prophylactically for DVT. I mean, we are great believers in the mechanical system of prophylaxis. DVT prophylaxis, we use mechanical pumps, DVT stockings, very early mobilization. We use enoxaparin for the duration of hospitalization and aspirin as they go out, particularly now with the COVID. And most importantly, do not manipulate, and tell your physios not to forcibly encourage increase in movements, because these will end up with fractures, patellar fractures, loosening of the implants. So this is something that you need to talk to your physios about and make sure it does not happen. So we'd like to just go on to this surgical video. And at this point, may I just suggest, please feel free to ask questions as you're going along. So this is a very severe osteoarthritic patient. We use a vertical midline incision. And we use a cautery to do a fairly generous medial release. At this stage, what we do is we take out these intercondylar osteophytes. This will decompress your anterior, your PCL. You've already excised the ACL. So all knee replacements are ACL deficient. You really have the choice of retaining the PCL or not. This is the white side land that we were talking about. And this is the transepicondylar axis. This should cut at right angles. And this is really what we follow in all of our cases. This is the intramedullary jig going in. This is the persona system. I was actually both privileged and blessed that I was one of the developers for the persona system. So I know this system rather well. It's an elegant system. That's not to say that other systems aren't good. They're all very, very good, but we just work with this. I do the distal resection first, as you can see over here. And once we have done that, this is at 5 degrees of valgus. Once we've done that, we next use our sizing option. And between sizes, for a CR, you downsize, for a PS, you upsize. You then, this is the femoral finishing guide. You need to be a little careful as you go to the back. You have the chamfers, the anterior resections, and make sure you try not to notch the anterior cortex. Very important, because that is one of the forerunners of a supracondylar fracture, particularly in elderly, obese, osteoporotic female patients. So once you've done this, we remove the intercondylar osteophyte and posterior osteophyte. You can see over here that the PCL is getting tented. So we are removing the a large intercondylar osteophyte. And right next to that is the posterior osteophyte. And you can see that we have removed both of these. And this very nicely decompresses the posterior cruciate ligament. So you balance the medial and lateral side, and you balance your PCL with your patellar tendon. And at that point, you'll usually find If there's any loose body sitting there, you can take a Coker's and basically just try and remove that. So once you've done that, you then do your meniscectomy, or if there's any residual meniscus left, you try and remove that. And this is a classic methodology that I learned from Dr. John Insall many, many years ago. By releasing your lateral meniscus, you can actually subluxate the knee forward. You'll notice we are not using any Hohmann retractors. This is one of our specialties. A lot of people wonder how we do it, but you can see even without a Hohmann retractor, we can sublux it very nicely. We then use the tibial resection guide, and it has 10 millimeters and 2 millimeters, so it's 10 millimeters from the intact surface or 2 from the defect side. And fundamentally what you want to do is to try and keep your posterior slope similar to what you had with the patient pre-operative. So you reproduce the native slope of the tibia. One of the tips I would like to suggest is resect very, very, very little tibia. I mean, they recommend 10 millimeters. Almost always our resection is about 6-7 millimeters at the most. And the more severely deformed the knee is, remove less and less tibia. That will give you a very stable knee, particularly as in our case, we are cruciate retainers. It works very, very nicely. And you can see here that even in this very severe deformity, we are managing to retain the cruciate, and we are taking it out from the back. You can see the intercondylar notch very nicely. You then size your tibia. Again, with the Persona system, you have a wonderful option on sizes. And I don't use spacer blocks. For those of you who are wondering how we're doing this, we use the trial implants as our spacers, and it takes 2 steps out of the surgery. It hastens it, and by doing it this way, we are very well within the comfort zone of knowing how good your trial is going to be and how good your implant is going to be. So once you have satisfied yourself, one of the other things with the Persona is you can go up or down by a millimeter without actually having to remove anything. We call this the SHIM, S-H-I-M system. We can just take this little metal piece and just bang it in, and it goes from 10 to 11. Otherwise, you'd have had to remove the femur, then the tibia, and then redo the whole thing. This is a very elegant system. So this is one of the advantages of some of the modern systems that we have. So once you're satisfied that you have a good stability, check the stability in full extension, 30 degrees flexion, 60 degrees flexion, 90 and 120. Always don't do only extension and 90 degrees flexion. And that's what we're trying to do over here. So once you're sure that you've got your sizing right, you drill your lug holes for your femur, and you can see over here that your PCL is beautifully maintained, and you are now ready for the final cementation. Just a word about the cementation: make sure that your bed is completely dry. So we use suction irrigation. You size your tibia. This is an asymmetric tibia, and you align the rotation in line with the what we call the Agaki line. That is the line from the attachment of the PCL to the tubercle middle third. This we are using the keel guide, and so all our bony preparation is now done. At this stage, any final tuning, any little residual osteophyte that you have, this is the last step of preparation. We drill multiple holes for good cement penetration. This is a 1.8 or 2.7 drill bit, multiple holes, about 20, 25, 30. This is the periarticular infiltration that I was talking to you about. This has adrenaline. This has 2% sensocaine, clonidine. Of late, we've been injecting tranexamic acid into the subcapsular area to reduce bleeding. Our typical blood loss is in the region of about 150 to 175 cc. So on a bilateral, we lose about 250, maybe 300 cc. We try as far as possible not to transfuse our patients. We know for a fact there's enough evidence that transfusion is one of the leading causes of infection. So we repeatedly use lavage, and this is your femoral component, and you remove any extruded cement, and that's your post-operative X-ray of the patient who was severely subluxated, and that is the end of the surgery. So with that, I come to the end of my presentation. I want to thank all of you for the opportunity to present to this wonderful group of friends, and I'm very happy to take any questions that you might have. And
thank you, sir. It was a wonderful presentation, and video editing was absolutely fantastic. So, Dr. Shamsul, if you can just, or Dr. Ashok, if you have any questions coming up before we take on some of the questions that have come to me. Any question that has come up? Okay, Dr. Vipin, you want to just go ahead, please ask your question. You have raised your hand.
Yes, sir. Ashok sir, I usually do PSNI, and I would like to take guidance from you that I used to play with my femoral rotation, and sometimes I sacrifice popliteus tendon as well to play with my rotation component. But I had been scolded many times. But I would like to have your input about this. That I play with femoral rotation, and particularly in those.
So Dr. Vipin, in my the way I would answer that question is, in the knee, when you're doing a replacement, there are two structures I would try my very, very best not to touch. One is the medial collateral ligament. One is the popliteus tendon. Medial collateral ligament, because it causes medial and posteromedial instability. That is still relatively easy to handle. Or releasing the popliteus tendon, which is actually leading up to posterolateral instability. And that is a very, very difficult instability to treat, because the minute you get that, your tibia actually starts to fall back and rotate. And the minute you flex beyond 45 degrees, the posterolateral corner will actually fall into the back of the knee. And the only way to correct that will be by doing a TC3 or a CCK or LCCK or a hinge. And popliteus is really a very benign structure, even in severe valgus knees. You know, I take your point, you know, it makes surgery very easy by releasing the popliteus, but it also exposes you to this potential danger. So release up to the popliteus if for a valgus knee, and in a varus knee, don't touch it at all.
Oops. Well taken. Thank you.
And sir, when you're dealing with severe varus deformity with some defects, and how do you plan those defects while addressing them? Do you use screws or do you use augments? Do you use rod along with the screws? So how you go about it? Do you have any particular rationale when you're
Right. So great question. So basically, when you see a defect, if it is up to 4 to 5 millimeters, particularly on the medial side, it will usually come off with your tibia. If it is 6 to 7 millimeters, I would again say don't try to go to the base of the defect. Do your resection, recognizing the fact that defects are very easy to deal with. Gaps are very hard to deal with, because the minute you drop it down, you've changed your joint line. The minute you change your joint line, you're opening yourself up to instability. The minute you open yourself to instability, you're going to end up with a patient who's going to have fabulous range of movements. He's going to bless you, he's going to praise you to the sky for the first 6 weeks and then curse you for the rest of your life. So resection is minimal. Up to 4 or 5 millimeters, it will come off in your tibial cut. 7 to 8 millimeters, just downsize your tibia, lateralize it, do a reduction osteotomy. That works very well. If it is 10, 12, 14 millimeters, and you've done your 6, 7 millimeter resection, you've done your downsizing, and you're still left with about 4 or 5 millimeters of a gap. If it is less than 1/4 of the AP dimension of the medial condyle, just use a short stubby stem, cement it and get away with it. If it is half or more, use a longer stem, use a bone graft, use 2 screws, and the 2 screws, one goes posteriorly transversely, one goes anteriorly and laterally. So both ways you are sort of in that direction. It's a divergent screw.
Divergent screws.
Yeah, and as you tighten this, so you put your implant, you put your cement, drive your screw in about 2/3 of the way, and as you are driving your implant in, start tightening the screw so that graft takes the optimal position. It does not interfere with your stem placement, and you'll get a very snug. And the good thing about grafts is that they will always, if you have done the basic fracture management technology, right angles to the defect, they will always heal. We now come to a situation where there's a massive defect. There's no medial condyle at all. Now, in those cases, you would use an augment, or you would use a block, you would use a wedge. And more recently, we've started to use augments in the form of cones, tantalum cones, TM cones. That's been a game changer. So in these really difficult, some of the rheumatoids that we get, you put your hand in, the whole thing falls apart. Use a tantalum cone. The downside of a tantalum cone is it is very, 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 very expensive. Very expensive. One small tantalum cone costs about 1.4 lakh rupees. And if you use that, you have to use a stem. That adds another 40. So basically, you're looking at almost 2 lakhs up in the cost of just the tibial component. That does not include your femoral or tibial and the bone cement. So if costs are not prohibitive, and that's not a concern, this is a way. If you're really pushed against the wall, that would be the way. If you're using big augments, big grafts, use long stems. If you're using short stems, short grafts, use a short stem. Short stems should be fully cemented. Long stems should be breast fit. That is the kind of philosophy generally that we use.
Right. No, that's absolutely perfect, sir. You answered almost all aspects of the defect management in 5 minutes. Any other questions, Arvind, Shashikant?
Good evening, sir. You said very rightly, don't touch popliteus. And you also said, I usually don't touch the MCL also. That is true concept in terms of isometry nowadays taken out on the medial side, considering the MCL and the medial condyle of the femur, particularly if you think about the kinematic alignment. So, but as we are discussing the severe varus deformity, so many a time severe varus deformity having this so much contracture on the medial side. So in that case, usually we do release of the MCL and sometimes complete release of the MCL. But at the same time, it causes the instability, particularly in the flexion, knee flexion. If you flex the knee and you see there is opening more on the medial side and less on the lateral side. So what is your take on in such type of cases with very severe varus that we usually encounter? In our scenario, we have most of the cases with very severe varus knee. It's not ideal grade 3 or grade 4 or something like that. Yeah. So what is your take on in such type of situation?
So wonderful question, Dr. Arvind. So we have, so typically what we've actually written about this, and we have actually submitted this into a couple of journals who have, believe it or not, actually not accepted our article. And I'll tell you my philosophy for these kind of knees. The kind of knees that you're talking about are usually knees with severe varus. They have a little component of external rotation, and they have a subluxation. So your knee joint is this way, it's this way, and it's fallen back.
Perfect.
These are the cases where in a varus situation, we actually do a posterolateral release. We release the capsule posterolaterally, just in the region of the popliteus tendon. We don't touch the popliteus. We release the posterolateral capsule. The differentiator from a valgus knee is valgus knee. You start right in the front of the anterior part, release the iliotibial band, and go all the way back. In a varus knee, where we're releasing the posterolateral corner, we only take the posterolateral corner about 2 centimeters and we release it. The minute you do that, you'll find that the subluxation corrects. You're able to rotate that tibia back in place, and you're basically able to reorient your knee. If you've done this also and you're still not in a position to correct your varus deformity, you have two options. One is you can do what we call the pie crusting of the medial collateral ligament. A lot of authors do it, a lot of work people do it. Something that scares me, honestly. The other alternative is to do what is called a medial epicondylar osteotomy. It's you just take down the medial epicondyle, slide it down, and fix it with 2 screws. So these are things that are available that a lot of surgeons do use. But in my experience, we have done neither of these. We do a very, very, very radical posteromedial release. We will sometimes take down the PCL in these cases, reduction osteotomies. And if at the end of it, we would release the pes anserinus in these cases also. And as a last resort, we will, in extension, take an osteotome and drive it down the medial side of the tibia, almost down about 6 to 7 inches, releasing subperiosteally the superficial collateral ligament. That way, it is in continuity, it is lengthened, and we protect these knees in a brace for 4 to 6 weeks. And you will find that these knees will be in about 3 to 4 degrees of varus post-operatively, which is fine, because that patient has been walking on that varus knee for 10, 15 years, so they don't mind walking on a slightly varus knee, but you will have a mechanically and a biomechanically and a kinematically aligned knee. So without actually aiming for a kinematic design, you've actually achieved it.
Yeah, true, sir. It's so. Yeah, so about the condyle or epicondyle osteotomy you discussed. So about this valgus knee with lateral epicondyle osteotomy, I trained under Dr. Greichen. You must be knowing from Germany.
Yeah, I do.
Yeah. So he used to do almost in 90% of the valgus knee lateral.
His center, they're very keen on doing in valgus knees quite a lot, actually.
Yeah.
So, but
because they completely depend upon navigation. So we have to be, so if navigation tells them completely, it's 100% navigated, they do. So if the navigation tells them that they are off, they completely go ahead and do the condylar osteotomy.
Yeah. Their threshold. No,
sir.
Please go ahead.
Sir.
No, their threshold for deformities is very, very different to ours, because if they get like 10 degrees of varus deformity, a lot of them, particularly, I've been to the endo clinic many times. Thorsten Gerke is a very dear friend, and his predecessor, Joachim Lohr, was a very dear friend. So I've actually been to endo clinic. I've operated there several times. And I'm actually very surprised. 10 degrees of varus out there gets a link hinge knee. They just chop off the femur, tibia, bang it in, put a hinge, and end of story. So that threshold for deformity management is very different to ours. But you're right. A lot of people in Europe are very fond of doing lateral epicondylar osteotomy for valgus knees. It's not a bad surgery at all. I think, if you fix it well, it does quite well.
I discussed with him about the medial epicondyle osteotomy. So he usually don't do this medial epicondyle osteotomy in spite of so much of belief with the lateral epicondyle. He said with the medial epicondyle, there is a lot of structure attaches there, like MPFL get attached.
Right, absolutely.
Yeah,
you're right.
So other structure also, adductor magnus is just nearby. So doing that osteotomy will disturb this anatomy at the same time, not like lateral epicondyle where only lateral collateral ligament get attached.
I think that makes perfect sense. Makes perfect sense.
Yeah. So usually he don't do this medial epicondyle osteotomy at all.
Yeah, I think I'm going to be great friends with him because I totally agree with that.
There are couple of questions that have come up on our social media platform. I take that question to you, sir.
Yeah.
So I think Dr. Milind has asked about what are your indications for using a rod in femur and tibia both. So that's one. So that's, if you can answer that first, and then I'll take the second.
So Milind, typically, I assume you're talking about a stem in the femur and the tibia. Yeah. So stem in the femur will only come up in revision situations, or in a situation where there is a extra-articular deformity, or there's a supracondylar deformity or a fracture, and you're doing a primary knee in those situations. Otherwise, in most cases, femoral stem extension is usually not used. Most femurs, I know DePuy has an option of using an optional stem. Most of the others do not. If your consideration is because of osteoporosis, then yes, you can use it. Depending on what sort of system you use, you can use a primary or you can use a revision stem, revision femur. On the tibia, it is far more used for indications like there may be a stress fracture, there may be a high tibial osteotomy that's malunited, you want to get your alignment. There may be a bone defect like we just discussed a little while ago. So tibial stems is a lot more commonly used than femoral stems. And the only thing I would say is with augments and grafts, use stems because they de-stress the junction. As we're going along, more and more companies are running away from augments because these are large metal blocks, they're metal chunks, demarcation, stress, risers, loosening, attrition, all of these are being reported. And today, like I said, if cost is not an issue, a lot of these patients will just go and get a sleeve or a cone and end of story, you know. So I hope that answers your question.
Yeah. I think so. And he has also asked one more question, your opinion regarding deep designs. So what is your take on these designs which are there in the market?
Brilliant. Absolutely brilliant. I mean, let me, if I can be allowed to be very provocative today, let me make a, let me make a prophecy. Let me make a prediction. In 5 years from today, PS knee will be obsolete. It will be on the shelf of a museum. Every company is running away from PS. People are running away from the fact that you're taking out good, healthy bone. And even the gurus who advocated PS knees are all shifting either to CR or to what was just mentioned, the deep dish. So deep dish actually functions like a PS knee. Deep dish again has various connotations. You can have what we call the ultra congruent. You can have the medial pivot. You can have the medial congruent. You can have the mid-level constraint. So it's a great option. And my opinion about deep dish is it is here to stay. It'll get more and more popular. And as the originators of the PS start to retire, and the young guns like all of you, I mean, we're also in that phase of in the twilight of our careers, but all you young, bright surgeons, I think you will all embrace the deep dish. And I think that's the way to go. Absolutely the best way to go.
Absolutely, sir. I think you have made a very, very valid prediction, which is, I think it's happening all across the world, and it will come. It will definitely penetrate in India sooner than later. And there is one more question from Harmesh Kapoor, that if suppose you have done your cement implantation and you find that patella is not tracking well, what are your tips and tricks? And I suppose he wants to ask, if you are not replacing the patella, then what is your, and it was a varus knee, if I can add, how will you go about it if they are maltracking and you have already cemented your components?
So, Harmesh, great question. We see this, and the best way I can answer it is, before you cement, make sure that your patella is tracking well. The prevention in this situation is the best way, because if you have the situation that you're describing, that you have cemented your components and your patella is not tracking, before I tell you what you should do, I'll tell you what you should not do. Don't do a lateral release. Don't do a medial plication. Don't do a tibial tubercle shift. All of those three will fail. The only reason your patella is not tracking well is because you have your rotation wrong. That is the only way. If you have done everything else properly, your patella should not track. Either it is mal-rotated in terms of the femur or the tibia. Most often it is the tibia. Tibial internal rotation will cause lateral subluxation. Femoral internal rotation will cause a severe malrotation, and the minute you flex it, you'll find that you will not be able to flex it beyond, and you hold your patella in place, you won't be able to flex it beyond 35, 40, 45, 50 degrees. That is your telltale sign. So if, to answer to your question, you have cemented, your patella is not tracking well, unfortunately, you're going to have to revise that knee right there. Take out the femur, check out your tibia, and redo the whole surgery. And this is a patient where, because you have now recently done femur, recently done tibia, I would not shy away from using a stemmed implant. And I would not, both on the femur and the tibial side. If you're comfortable, if you are good with revisions, you are slick with removing implants, they are very easy to do. Particularly if you've just cemented it, knock it out twice hard, it'll come out. But if it is really set, and you're not really comfortable with it, don't hesitate to go on to a stemmed femoral and a stemmed tibial implant. Right. But correct your rotation. Do not correct by trying to realign the patella. That will not work.
That will not happen. Okay. So one more question has come up. In valgus knees, what is your preferred exposure? Do you go still medial parapatellar or you go lateral?
Yeah. So Sudeep, for all my knees, every single one of them, primary, revisions, medial, lateral, I use a vertical midline incision. I use a medial parapatellar incision. For primaries, I will go just about a couple of centimeters proximal to the insertion of the vastus medialis. I do not typically evert the patella, I just sublux the patella. And if it's a stiff knee, if it's a difficult knee, I do the rectus snip. So I don't do the viviplasty, I do not do the typical tibial tubercle osteotomy, but I do an extended rectus snip, go all the way into the vastus lateralis. And even with ankylosed knees, that has worked in my hands. There are obviously other ways, but I just feel by doing that, you're not disturbing the tibial tuberosity. And these are very, very easy to do. Your post-op rehab is exactly like a primary knee. You don't really need to worry about it.
Right. And one more question, sir. Yeah, okay. Yeah, please, Nishant, go ahead.
Sir,
yeah.
Sir, what is your opinion about the resurfacing the patella? Are you doing every cases or in selective cases?
So, in my whole career of almost 34 years, I've done about 34 patellar resurfacings. I almost never do it. Again, this is a very interesting question, because it's again a very interesting trend. A lot of people are now running away from replacing the patella, and again, all the gurus who earlier on is to talk about patellar resurfacing being mandatory. Today, if you look at the Australian registry, and I think the best way to answer that is to look at the registry data. 53% of surgeons around the world do not resurface the patella. 47 do. And of course, if it is regional, if you look at the UK registry, almost 75% do not resurface. Within the US, almost about 70-75% do. But interestingly enough, a lot of the surgeons who are the big names are not resurfacing or doing selective resurfacing. And the reason for that, when I talk to them, it is because of the medical legal implications. They are worried about the fact that the patient might sue them. So given a choice, a lot of very, very prominent surgeons who believe in patellar resurfacing today are not resurfacing the patella.
What about the denervation of the patella?
So that is one thing you should not do. The reason for that is it causes avascular necrosis.
Yeah.
And we have seen, I won't say a lot, but we've seen about 15, 20 fractures of the patella with minimal trauma. So you actually don't need to do that. Just take away the osteophytes. Basically, you want to make sure that whatever patella you have is sitting nicely in the trochlear groove of your femoral component. And as you take it from 0 to 110, 120, it should not shift laterally. If you do that, I think you're in a good place. You're in a very, very good place.
I think, sir, you shared the data from the England and Wales registry. I think Scottish registry, they don't contribute to the England and Wales registry. And my first-hand experience working there for a year and a half was that absolutely 95 to 99%. I'd never saw with both my consultants ever replacing, and other hospitals also, they never replaced a patella until it was severe valgus or one-off, I guess. But I never saw any X-ray where they have replaced a patella.
Right.
And I think electrocauterization, I think, is also now people are shying away from doing it. We are doing a randomized trial, but results will be known, I think, in a year or so. We've just started, but it seems easy to just electrocauterize everything, but rationale behind it, we don't find any solid rationale behind it. So that's why we thought that we should be doing some research work on it.
No, that'll be a great study. If I can sort of put my hand up in the queue and say, please do let me know what your outcomes are. We'd be very, very fascinated.
Yeah, we've just got our ethical committee clearance, so we'll go ahead and
wonderful. No, I think it's a phenomenal subject. It's fascinating because I don't think too many people understand what the patella is doing in knees, even in a normal knee. So in a replaced knee, the knowledge is even less. So it'll be a fascinating study. So, good luck, and keep us abreast of what's happening.
Sure, sir. Thank you. Sir, a couple of more questions to you regarding your practice. So what are your DVT prophylaxis, how it has changed over the years? And second is your use of tranexamic acid intra-op, and during what is your regime of using the tranexamic acid? Yeah,
so all my patients get a shot of Trenexa as we start the surgery. We give intraoperatively, we inject Trenexa, and all patients get a shot of Trenexa the following morning. So we use 3 doses of antibiotics and we use 3 doses of Trenexa. So our antibiotics is 2nd generation cephalosporin with induction after 8 hours of surgery and after 24 hours of surgeries, and that's it. We use regular cement except for revisions where everybody gets a antibiotic cement, and that's usually a combination of gentamicin and I think it's one of the other antibiotics, one of the newer antibiotics. And Trenexa, every one of these people get. In terms of DVT prophylaxis, for many years, almost about 20, 25 years, we used no prophylaxis at all, which I think that was a mistake, but we weren't really sort of really sort of well in with this. Today, we have a pretty exhaustive protocol. Every patient, the minute the patient they get to the post-op, they get into a cryo jacket. We use DVT pumps. We use the TD stockings, early mobilization. All of our patients sit across the bed within 4 to 6 hours of the surgery. We do all our surgeries through a short spinal anesthesia. Fortunately, we are blessed because we've had the same team for about 25 years, the same set of colleagues who work with me, anesthetists, my technicians, my scrub nurses. So it works pretty efficiently. So our typical operating time for a unilateral is about 20-25 minutes. Bilateral is about 40 minutes. We're out of the operating room. So the spinal anesthesia effect is 2.5 hours. So by 4 hours, they're sitting across the bed. 6 hours, they're standing up. And usually they'll take a walk around the bed. The next morning, they go to the washroom. By evening, they're walking in the corridor. We thanks to Corona, one of the things good things that has happened is Corona is all our patients go home in 48 hours after surgery, because we don't want them. But right now, our DVT prophylaxis includes heparin for 7 days, and we continue with Ecosprin for a period of 3 weeks. That is purely sort of dictated by the Corona, because so many of our patients are high D-dimers and stuff. Right. So as a policy, we have started doing that.
Right. Excellent, sir. And sir, since you mentioned bilateral TKs, so just a small query. How do you select your patients, and how do you go about doing a bilateral TK? And what's the percentage like if you get a patient with both knee and he wants to get it done by you? How you do that? How you select patients, or you do all the patients bilateral if they're happy to get
there was a time when we did everybody. Again, these 30 years have taught me a lot. One of them was to recognize that there is science behind everything that we do. And the best article was, there was a consensus meeting in 2013-14 by Javed Parvizi in Philadelphia on bilaterals. And from about 13-14, we have started following that. So our criteria is anybody under 75 gets a bilateral. Anybody over 75 does not get a bilateral. He gets a staged. And by staged, we mean we do one, wait 48 hours, get a complete evaluation, then do the second. Patients under 75 have to be ASA grade 1 or grade 2. They should not have more than one comorbidities in terms of cardiac, renal, respiratory, or liver issues. And they should not have any pre-existing history of something like DVT or embolism or clots. So we are very, very selective. But in spite of that, to answer your question, in my practice, about 80% are bilaterals. 20% are unilaterals. We have become a little more careful with COVID patients. So we are very, very, very cautious with them. So a lot of them, at the slightest drop, we will go into a split mode. Sometimes we are sending them home, getting them back, but that's not a usual practice. Most patients will get a bilateral.
But more or less, your criteria is very clear and strict when how you choose your patients for unilateral and bilateral. So that's actually really nice. And do you use tourniquet for all unilaterals and bilateral cases? Do you use tourniquet?
So all elderly patients where we're doing staged, we use a non-tourniquet approach. We've also developed a bit of a crazy technique. I call this the extra-articular technique. So we use the same instruments, but we do not actually go into the medullary canal of the femur. We do an extra-articular. I have a little contraption which I devised many years ago. So that gives us a very good alignment in terms of cutting the distal femur at right angles. So I call that the extra-articular approach. Okay. So because you're not breaching the medullary canal, the blood loss is almost negligible. They're fundamentally just 5 arteries around the knee. 3 on the medial side, intercondylar and lateral superior genicular vessel. I mean, once you've got those 5, it's dry as anything, and plenty of lavage, tranexamic acid, and it's like doing a tourniquet surgery.
So basically, mostly no tourniquet in your practice, other than when you
Predominantly not.
Predominantly not. Okay.
Yeah.
Fair enough, sir. I think one question has come up online from Dr. Milind. Any tip for a patient having habitual dislocation of patella preoperatively? So you have any tips for habitual dislocation of patella going for a total knee?
So are we talking about a patient just with habitual dislocation, or are we talking about a patient undergoing total knee replacement with a habitual dislocation?
I think undergoing total knee replacement with habitual dislocation, I think.
Right. So let me start by making an honest confession. These are very, very difficult knees to deal with. Most of these patients have a hypoplastic trochlea. They have usually a valgus knee. A lot of them will have some kind of a dysplasia, like the Marfan syndrome, Ehlers-Danlos. So these are patients that you need to be very, very careful about. So in these patients, I would actually this is the only case where I would actually internally rotate the femoral condyle just a little bit to orient the patellar tracking, do a very, very light wide lateral retinacular release, and keep the tibial rotation also neutral to about 2 degrees internal rotation. I would put my trial in that position, hold the released patella in its normal alignment, put 2 staples or 2 towel clips, take it through a range of motion, and then make sure that I have, so this is the only time when I will not actually use landmarks to fix my components. Right. I will do that floating technique and see where it comes up.
Where it lands.
Only time I would do this. And we've done about 6 of them using this. With 4, it worked. With 1, it subluxed a little. And with the 6th one, unfortunately, it was very severe. And we could not actually correct it. And we had to go back in again. A second time, we had got our rotation right. We then had to do a tibial tubercle osteotomy, moved it medially and distally. Patient lost flexion, but had a stable knee.
Right. Arvind, yes, please go ahead.
I have experience with one case, sir. So I approach is through the lateral approach directly and did the tibial tubercle osteotomy at the same time.
Right.
So with lateral approach and anteromedialization of the tibial tuberosity, and rest was like standard, other than the tibial should not be externally rotated and femoral should be almost neutral.
Yeah. No, I would agree. No, I think that's a great approach to take. This would actually, you're absolutely right. This would be the indication to use a lateral approach, because you're doing a lateral release as you're going in, and it makes absolute sense to do that. Yeah, absolutely right.
Yeah, but when you're going lateral exposure, you need to be very careful. You have to dissect the capsule and the inner layer separately so that you can double press them or oppose them. Otherwise, you will end up struggling if you're not routinely doing lateral approach.
That's right. Yeah.
So that is the biggest problem with lateral approach. Yeah. So if the dissection of your lateral approach is not very proper, at the end of surgery, you will see your implant is exposed. It don't have any coverage of the tissue other than a skin flap. So that dissection part and the closure with the capsule and the deep fascia is very important.
Right.
And so you're using drain for patients or not using drain, or any selective selection of patient whom you will be using drains in your patients?
So rheumatoids we use because they bleed because of the synovial proliferation. We do synovectomy. Revisions we use it, but we use it for only about 12-14 hours. Usually by early next morning or late evening, we take them out. So we've gone through the phase where we didn't use it, we came back to using it. Somehow I just feel using it makes the bandage less messy. It freaks out the patient less because the relations come and they say, you know, patient, आप मेरी बीबी के टांग से इतना खून निकल रहा है, डॉक्टर साहब क्या कर रहे हो? So I mean, for peace of mind of everybody, we pretty much use it for a very short duration of time now.
I think that's the trend. I think in India mostly
Yeah,
they're using it less and less, and those who are using it taking it out very early,
very early,
or clamping it for a longer duration and opening it late, and then
absolutely, absolutely.
Right. Any other question, Mahesh, Vipin?
So regarding the use of tourniquet, what is my perception? I would like to take advice from you. That I see if I'm using tourniquet, which is essential for cementing, but if I use if I say my anesthetist to cooperate with hypotensive anesthesia, I feel that they have less intensity of thigh pain. But I would like to enlighten.
I think no, I think you're absolutely right. There are two aspects. One is they have less intensity of thigh pain, and they have less quadriceps inhibition.
Yes.
SLR becomes a lot easier. If you do not use tourniquet, you ask the patient to straight leg raise, they do it effortlessly. And thigh pain, particularly since most of our patients are female, proximal thigh is heavy, there's a lot of fat. And by the time, you take the tourniquet off, that subcutaneous fat, it's blue and green, and they get worried about that. The family gets worried about it, and the pain is quite intense. So you're absolutely right. I mean, we are trying to use tourniquet as little as possible now. And if you're using hypotensive anesthesia, you really don't need to worry about it. You know what bleeders to catch. I mean, there is no sixth bleeder in the knee joint. And if you are using intra-articular tranexamic acid, as I think most of us are, it's not a challenge at all.
So do you use hydrogen peroxide as well, sir, while you are waiting for cementing? Never use.
Never. We just do lavage, high intensity, high pressure lavage, dry it out till you can see the trabeculae, and just bang it in, and that's the end of it.
And you mentioned in your talk about psychological issue. Do you have any objective criteria to measure any of these? Do you do it routinely, or it's just while interacting with your patient you can get a feel that okay, this is the one that is going to be a troublesome, or you should be advising against the surgery, anything like that?
Yeah, I have a couple of pretty strong points. Anybody who comes with a daughter who's armed with Google information, avoid her like the plague. Anybody who's taken 6 opinions and wants to know what the length of the incision is, do you release the PCL or do you substitute the PCL, avoid her like the plague. Anybody who says how many knee surgeries have you done using this approach and that approach, avoid her like the plague. I basically don't mind answering questions, provided you know what you're asking. Most of these patients have no idea what they're talking about.
Cross-checking, just
they talk about AI, and I ask them what does AI stand for, and they don't know, and that becomes a little difficult to answer. So then my typical answer is, would you rather be treated by AI or AR? So they say, what is AR? I said, you talked about AI, I'm talking about AR, augmented reality. So, I mean, today, I think people are getting carried away by advertisements, by media, by social media. A lot of people claiming that their knees replacements have zero pain. They go home within 4 hours. They flex fully within 6 hours, 8 hours. They have no rehab, no physio. So I think somewhere we need to be realistic in our attitude. So, the best way is to be honest about it. It is a painful surgery. It's going to be uncomfortable. It's going to be uncomfortable for 3 months, maybe 4 months. And if you look at the protocols that they follow in places like Philadelphia or at Hospital for Special Surgery, including Europe, they're all told that you're going to have some discomfort for a year. End of story. Females will have it longer, males will have it shorter. Everybody's going to have it. I mean, you want it, we'll do it. I mean, in spite of everything we do, there will be some discount.
Absolutely. So actually in Germany, I think the indication is that they will book a physiotherapy appointment for after surgery, patient 2 months, and then they will book a date. Unless until that is confirmed, they will not book a date for you.
So I feel so because patient they do ask. So I say कि एक मैं जानता हूँ एक joint replacement 3 से 5 महीने गाली खाएगा, and they are comfortable that I am going to feel this for 3 to 5 months, and no further questions I receive from their side.
I think you are very lucky if your patient stop bugging you after 3 to 5 months. Ours go on for a year.
Right. I think so. It was really, really wonderful, and I think we don't have any other questions. Any other panelists? Yeah, Arvind, please go ahead. Yeah.
2 questions, sir, I have. One is, we all know the femoral rotation and all the landmark. About the tibial rotation, usually we take the posterolateral corner, get covered with the tibial trial. And then sometimes this medial condyle is big. And when you rotate this, so all the time I have little bit confusion where I am going 1 to 2 degree more external rotation or little bit 1 to 2 degree or 3 degree internal rotation, because that line of that tibial tray that passes through the tibial tuberosity is not always accurate. So along with that posterolateral corner, what structure on the medial side you take consideration for considering this tibial rotation component, preparation of this tibial part about the rotation?
So, great question. We have published on this, and I'll tell you the easiest way where you'll get it right 110 times out of 100. You take the resected surface of the tibia, all right?
Yeah.
Take your trial and put your trial so that the anterolateral part of the tibial tray matches the anterolateral part of the resected tibial surface. Just do that. Forget about everything else. So this is what we call a curve on curve approach, which means that your anterolateral resected surface matches the anterolateral curvature of your tibial trial. Just pin it in that position and prepare it. You cannot go wrong. You will never go wrong. And if you have a asymmetric or a symmetric tibia, some part of the bone is left uncovered on the posteromedial or medial side, just remove it or upsize your tibia. By doing that, what you're doing is, you see the tibial tubercle, you're right. Tibial tubercle is a very vague anatomical landmark. What is 1/3 and what is lateral third and what is middle third and medial third? None of us knows. The position of the tibial tubercle relative to the proximal tibia has a 37% variation. If you look at different populations, patients in Punjab will have it different, patients in Bihar will have it different, patients in Bengal will have it different. So there's a huge anatomical variation. By doing what I just suggested, you are making it anatomic for that individual. Now, regardless of how you're oriented to the tibial tuberosity, that patella has to track normally. And your orientation of the tibial tray will be anatomical to that particular individual. End of story. You don't have to worry about anything after that.
Yeah. And second question, sir, about the release on the medial side or lateral side. Do you prefer first release or do you prefer first cut the tibial surface, then you release it?
So my exposure releases everything that I need to release. I will not make any bone cuts, except maybe the last 5% of correction. So if I have a varus deformity, before I make any bone cuts, I'll do all my releases. I'll remove the osteophytes from the femur tibia, correct it passively and make sure that I can correct it, say from 15 degrees of varus to about 5 degrees of varus. Last 5 degrees, I will do after I've done my bone cuts. So my exposure is my release. Valgus knee, I'll do the exact same thing.
So basically, you release on the medial side like PES and deep MCL.
Not the PES. PES is the last structure. The deep MCL is the lastest structure. But the capsule, the meniscofemoral ligament, will go up to the posterior middle corner, semimembranosus. If it is a severe varus, if it is subluxated, will release the posterolateral corner, like I mentioned. If none of that works, then I would go to the PES, and if that doesn't work, then I'll go to the superficial medial collateral.
So this message is the PES and the superficial MCL should be touched in the last.
Absolutely.
Otherwise, this leads to the mid flexion instability and other problem with that.
Absolutely. Yeah.
And I think there was a paper by Dr. Maniar as well, and I think one of the ROCs 3-4 years back, and he has demonstrated that you start from the back more than rather than the people start from the front releasing the MCL. So that's another, I think, is a bigger issue where you.
Yeah, that was the older concept. You just release everything on the medial side.
Everything, if you are and from what is right in front of you, start releasing it right across, and then go to the back, rotate the tibia completely. External rotated, and then anyway. So nice.
Just couple of words from you on the mid flexion instability, because in almost every conferences of the knee, this is discussed, and we all know that it's the real. Initially, it was thought that nothing like the concept of mid flexion instability. So just elaborate this concept of mid flexion instability.
Okay, I don't think I can answer that in 2 words. It's a thesis topic, but let me just say this. If you have done everything that we discussed, careful release, medial laterally, you will not get instability. Do not aim for getting high flexion. Knee replacements are not designed for squatting on the Indian style toilet. It cannot happen. If your knee flexes to 145 degrees within 3 weeks, you are flexion unstable. If you are able to touch your heel to your buttocks at 3 months, you are flexion unstable. The only way to avoid flexion instability is I treat all my knees like revision knees. I fix my flexion space, which is what I mentioned. Upsize your femur, restore your posterior condylar offset. That is the critical part, posterior condylar offset. If you restore that, you get your size right, you get your slope. I mean, a lot of times what happens is to make it easier, you start increasing your posterior slope of the tibia, flexion unstable. It's very easy to do. The easier a surgery becomes, you have released something that you should not have. A little bit of struggle is good for health. I hope that answers in a very short line. And most importantly, the last point I'd like to mention is any patient with severe fixed flexion deformity, do not remove more than 4 millimeters from the distal femur. If you do that, you're bound to end up with flexion instability. Release the posterior structures first.
Thank you, sir.
Thank you, sir. I don't think, sir, there are any more questions. I think you have answered more questions and you have given more tips than what we would have thought that we'll hear from you. Not short talk, but more and more tips that you have given us is really wonderful. I'm sure everybody will benefit. Every one of us, and every listener will benefit from all this short, small tips and your experience that you've shared. What speaks millions actually for us. I'll request, I think, Dr. S.N. Sarraf, sir, and Dr. Madhusudan, sir, our honorary president and secretary, to give a vote of thanks before we say thank you to you finally, sir.
Thank you, Dr. Sudeep. Am I audible?
Yes, sir, you are. Please go ahead. Yeah.
Thank you, Dr. Sudeep. Really, it was a very educative and interactive session. It was very nicely discussed and well demonstrated. So I would like to thank everyone for their time and efforts. A special thanks to Dr. Rajgopal sir, who has given the very valuable time for our association. We hope it was a very beneficial for all the members of the BOA, Bihar Orthopaedic Association, and all over the country. So I like to convey thanks to you, sir, Rajgopal sir, I like to convey thanks you on the behalf of each and every member of the Bihar Orthopedic Association, sir.
Thank you so much.
Thank you. Thanks, everyone.
It was a quite informative and educative session. Really, it was a mind-blowing session. We got many answers of many questions. Thanks to all. Special thanks to Dr. Rajgopal and a special thanks to Sudeep. He had many questions and many answers. Thanks to all.
Thank you, sir. And Ortho TV, not to mention, to forget these people who are really working hard, Shamsul and Ashok Shyam. Really amazing work that you guys are doing, and amazing means it's a small world, and world has really shrunk into just a laptop or a desktop. And we could hear Ashok Rajgopal sir for 1.5 hours, mesmerizing, and this could not have been possible. So there are some good things about this whole lockdown and everything. So, but Ortho world is
also
really
allow me, Sudeep, to take this opportunity to thank all of you, the BOA, and all the participants. It's been a wonderful evening. Thank you very much.
Thank you,
and we look forward, hopefully, at the next time to be with you all in person.
In person. Okay.
Yeah. Thank you so much. God bless. Stay safe.
Good night.
Good night.
Good night. Good night, sir.